Welcome to the EAU podcasts.
Hello, everyone. I'm Claudia Kesch, Associate Editor of UROONCO and a urologist at the Department of Urology, University Hospital Essen. And I'm here with Professor Jochen Walz, Head of the Department of Urology at the Institut Paoli-Calmette Cancer Center, Marseille. So today we are going to talk about the best of 2025 in low and intermediate risk prostate cancer, including imaging and diagnostics. And I'm very happy to be here with you, and thank you very much. And we dive in directly. And if you had to choose one personal highlight or breakthrough from 2025, what would that be for you?
Indeed, I think in 2025 we had several very nice studies being reported looking at diagnostics, especially of prostate cancer. The first one, I think, is the Optimum study coming from Canada, or like the coordinator was a Canadian group around Lawrence clots that looked at the performance of high-resolution ultrasound in the diagnosis of prostate cancer relative to MRI. So this was a head-to-head comparison where they had a look how much high-resolution ultrasound can go up to the standard of diagnostics in prostate cancer, which is MRI. And it was a non-inferiority trial, multi-center, and turned out to be that it was not non-inferior. So it is as good as MRI, at least in this study. And I think it is very good news for our patients. The early detection or screening is probably going to extend to a larger extent to other countries where this pre-biopsy MRI, as it is recommended right now, is not feasible. It's not affordable. It's too expensive, would consume and take too much resources and scanning times for an MRI. And the ultrasound approach probably is way cheaper and might be a good solution to go into these efforts and initiatives also on a broader level. It is also associated as MRI with expertise and to know exactly what you're doing and experience as well. So it's not like a very easy to copy paste what was done in this study, but that applies also for MRI. We know that high quality MRI is necessary in order to make the MRI pathways work. Excellence, expertise, and experience. And this is just something we need to establish no matter if we do ultrasound for diagnosis of prostate cancer or if we do MRI. But I think it's very good news for our patients and for initiatives we have ongoing for early detection that we have now other tools coming up. And we will see how that is taken up then in the near future. And would be nice to have like a study confirming these data, but it was already a multicentric, high level of evidence. And I'm pretty convinced that this data will be strongly considered for further recommendations in the near future.
Wonderful. Indeed, Optimum was one of my highlights as well. And it actually brings us to another question. I was planning on talking to you a little bit about the role of multiparametric MRI in the center of the diagnosis for prostate cancer and improvements in imaging. So I guess we already covered that a little bit with Optimum. But do you think there has been anything else in imaging for diagnosing low and intermediate risk prostate cancer we should add here?
So we still have obviously the discussion because the MRI is so expensive and so time consuming, if we can switch from the multiparametric MRI to the biparametric. And there was the PRIME study that was presented or published this time, was presented already, I think, 2 years ago at the EAU. But now we have the official publication showing that biparametric MRI performs as well as multiparametric MRI, at least in this prospective study. I still have strong doubts that this information can easily be applied in a general population, in the community setting. They had outstanding high-quality MRIs in their study, which I do not see in clinical practice, like PiQual 4 and 5 mainly in 90-95% of all scans. I don't think that is something we can easily reproduce. I would be more or less a little bit reserved about these results and say, okay, we can switch entirely from multiparametric to biparametric MRI in expert hands and in centers where they really check if they are as good with biparametric MRI as with multiparametric MRI. I think it's an option. But I would be very careful to spread that to all centers where MRIs are done. And I think the multiparametric part really adds a safety net to it and gives the possibility to less experienced readers and operators to succeed with the aims and the advantages that MRI actually generates. But yeah, we will also see how that is taken up. But for the time being, for me, the multiparametric MRI remains the standard. And it's interesting to see, even if you talk like to radiologists who might be the most interested to switch from multiparametric to biparametric, many of those who are very well established in the field of prostate MRI and diagnosis of prostate MRI, they prefer to remain with the contrast enhanced sequence because they think it's an added value and helps them to do a better job. So it's not just like an urologist saying that this might be difficult. Even those who really work every day with this sort of strategies, they also more in favor of multiparametric MRI than in biparametric MRI.
In the end, it's maybe not only the MRI we need to rely on, and there we also want to look a little bit at combinations with biomarkers and with artificial intelligence tools. And have we seen anything there in 2025? Are we closer to a fully personalized diagnostic pathway here?
I mean, I think we're doing already quite a nice job with the MRI that really helps us to stratify our patients and decide who might really need a biopsy or not. I think we went down with the number of biopsies we take nowadays. The rough data you get from several countries, so just thinking about data from Italy and from Switzerland, you see that the amount of patients that are diagnosed with low-risk disease is going down. So we really biopsy those patients where we really need to have a biopsy. So that's very, very useful, I think. But yeah, there's space for improvement. We can do better. AI will for sure be a tool that will be in there very soon. Not sure that we right now have it really ready for prime time. With biomarkers, I think Stockholm 3 is already out there and did provide high-level evidence that it is an added value. But probably the most interesting study I saw in 2025 was the Barcode 1 study from the UK, where they had a look at a gene panel looking at several genes associated to the development of cancer, not necessarily prostate cancer, but of cancers in general. And they decided if you're above the 90th percentile of this risk score that you can generate, you're at risk of having prostate cancer. And then these patients did undergo an MRI, did undergo a systematic biopsy, independent of what the MRI actually showed. And they had a striking high number of prostate cancers diagnosed. On the one hand side, a high number of non-significant cancers defined as isograde group 1, but also a high number of significant prostate cancers. And they compared this approach then with the current standards of diagnosis, which is a cutoff of PSA at 3, and then an MRI. And if that is positive with a Pirate score 3 and higher, then this would have been a biopsy indication. And if you would have applied this strategy, you would have diagnosed way less insignificant prostate cancer, that's true, but you would have missed also a substantial number of significant prostate cancers that were actually diagnosed with this sort of biomarkers. We need to be careful. That is not something you can extrapolate to the entire population. So you cannot say that so many insignificant cancers are missed by the current standard PSA and MRI. But if you select patients that are at the highest risk of having prostate cancer, then it seems that the current pathways is not sufficient, and that MRI might not be the optimal way in diagnosing the disease, and that probably in the near future, this sort of biomarkers might be of true added value to identify those who are at highest risk and that really need this sort of intensified diagnostics in order to get those cancers diagnosed. So it was really like something that I was not expecting. I was really surprised to see those results, especially once more of this very high number of what we still consider nowadays being significant prostate cancers that were not captured and identified by MRI. Again, very selective patient group, but suggesting that MRI is not the ideal tool in isolation for the purposes that we might have in this field.
Thank you very much. Yeah, we'll see if this goes further in the next few years. Well, let's move on a little bit from diagnosing to actually treating prostate cancer. Active surveillance is our preferred strategy for low risk and some favorable intermediate risk prostate cancer patients. Have we seen any relevant updates in 2025 according to your opinion here?
I did not see a breakthrough study looking at active surveillance. I think what is very important that it is becoming more and more a mainstay. Like the current guidelines, European guidelines recommend active surveillance as standard of care in low-risk prostate cancer patients. They do not mention any curative treatment at that time point anymore. And I think we need to spread that word, and we need to have that reflex in a patient that is just diagnosed with prostate cancer. We need to ask ourselves, can we do active surveillance in this patient? And if there's a possibility, we should do it. And we need to have strong arguments actually not to do active surveillance in these patients. And I think we can easily extend this to lower volume, intermediate risk prostate cancer patients. We know this patient will do perfectly fine if they get started with active surveillance to start with. Protect was showing this very nicely that after 15 years of follow-up, you can safely start with active surveillance in these patients. Would not mean that they would never get treatment, but at least you can postpone curative treatment for a certain time point without losing a lot of efficacy with regards of the long-term control of the disease.
Completely agree. We still need to educate patients and fellow colleagues better on really putting everyone on active surveillance who's a suitable candidate for that.
In addition, also, I think Protect told us that we can also go way easier with the follow-up afterwards. We don't need to do repeat biopsies like every year and do an MR every year and do whatever. Protect was very easygoing with regards of the follow-up and still seemed to be very effective. I think that's also important information that we can have a more open indication for active surveillance, and we can do the follow-up also way easier and less intense as what the current standard might have been or it might be.
Yeah. Nevertheless, ultimately, some patients will need definitive therapy. And let's talk a little bit about what we've seen in 2025 in advances regarding surgical techniques and perioperative management of the patients.
I think one point we might talk about, not a lot of data out there, really, like if we look at publications, but there was a single part system that was actually commercialized in Europe. And I think that is something that is good news for us. I think we need to innovate in surgery to make sure that we remain attractive for our patients. If we, let's say, would still do open surgery for treatment of prostate cancer in a systematic fashion, I think we might have been outdated already by far if we compare to what is happening in radiotherapy, where we switching more and more to a hypofractionated regimens, SBRT, where the treatment might have been done in 5 days only. And if you then see what open surgery might be as an alternative, I think it's not competitive anymore. And the minimal invasive surgery, I think, is what keeps surgery an option in this situation. And I think the next step will be indeed the single port approach, where you can do still a less traumatic intervention that is effective and probably easy to support by the patient. I think that's one point, not really data out there, but I think it's a technology that is very interesting. And then if you look a little bit more at science and studies, I think there was a NeuroSafe study which looks at the systematic use of NeuroSafe, a frozen section evaluation of the prostate during surgery to evaluate the surgical margins in real time. The UK study, once more, they're really excellent in driving those studies. We are all keen to have an answer to see if that is necessary or not. It showed an advantage by randomizing patients between NeuroSafe in a systematic fashion versus no NeuroSafe with regards of the erectile function. But I would say from a clinical perspective, the results were rather disappointing. So the difference you get, 3 points on the IIF score, might be statistically significant. Clinically speaking, probably it is not. The results are probably less enthusiastic than what we might have expected from it. On the other hand, I think it's an important tool because it helps to increase the amount of patients where nerve sparing might have been done or might be done. Get us into a situation where we might find the best compromise between the oncological results and the functional results. And again, if we would like to remain a good option for our patients, we need to strive to improve our functional results after surgery. And I think that is one tool that might help us. The results might not be that striking, but again, gaining 3, 4, 5 points on the IIF score might be enough to get a patient sufficiently good erectile function to make sure that he is happy with the results. And that might be a detail nice to add to your management of your patient and the strategy you have for your patients to offer.
Yeah, and having the tool, we surgeons might also be a little bit more confident in offering nerve sparing, I guess. No.
It's not like about surgical margins, I think, why you use it. It's with the aim to increase the indications for nerve sparing without having too much doubts about the oncological end point afterwards. So it gets you to the best way how you find the right compromise between functional results and oncological results.
Yeah.
Every additional tool, I think, is very helpful. If that is really like frozen section that is relevant, might be, but we have now also like a confocal microscopy. That might be a solution. Maybe also the PSMA solutions you're working at in Essen, that might be very interesting also for real-time during surgery evaluation of the tumor extent. I think all these tools are very much welcome in order to get the best compromise.
Let's move on to radiotherapy and do a little bit of recap what we've seen in 2025 here.
We talked about the SBRT already becoming more and more standard of care. I think the PACE-B study reported might have been even a year earlier. I think that's important, the comparison between normal fractionated radiotherapy and 5 fractions for favorite intermediate risk prostate cancer patients, showing no difference with regards of the oncological results and comparable results with regards of the toxicity. I think that is very interesting for the patients. The radiotherapy treatment might now be done in these indications, intermediate risk prostate cancer patients, just in 5 days, which is substantial improvement to what was done before, like with a monthly treatment or even a 2 monthly treatment, where it was really like a long treatment. But more important for last year, I would say, is the presentation of the ENSERAT trial, looking at the intensification of treatment in patients with high-risk prostate cancer treated with radiotherapy. It's an Australian study, and comparing 2 years of ADT plus radiotherapy versus 2 years of ADT plus 2 years of enzalutamide plus radiotherapy. Coupling a little bit was done in STAMPEDE, very high risk, where they added 2 years of abiraterone to radiotherapy and 3 years of ADT. And I personally thought this must be a positive study showing you a better outcome in adding 2 years of enzalutamide, but actually it was not. So there was no improvement in metastasis-free survival in these patients by adding 2 years of enzalutamide. And I think the lesson to learn is that you need to be of very high risk, very, very high risk, to get a benefit from intensification. And if you're not, a simple radiotherapy plus 2 years of ADT is enough. And the disease really needs to be probably some sort of micrometastatic or oligometastatic in order to really generate a benefit. And simple high risk is not like the patients where this is the case. So I think it was a year where we learned that in some patients we need to intensify, and in some patients we might de-intensify, and we really need to understand where that is necessary and where it is not necessary. And the same might apply also for the situation with biomarker recurrence. It's not like radiotherapy, but we had the readout or the long time follow-up of the EMBARK trial looking at overall survival, clearly showing that if you add enzalutamide in very high risk biomarker recurrences, in addition to ADT, you improve overall survival. And then the PRESTO study was reading out using apalutamide in a similar setting, but having patients that are way of less risk of having high-risk biomarker recurrence, and there actually adding apalutamide was not improving metastasis-free survival, so a negative study. So it seems that we really can, more or less with the tools we have nowadays, identify those where intensification is useful, and also those where it might not be necessary and just add toxicity. And I think ENSERAT and EMBARK plus PRESTO was really teaching us this last year. And it's very, very important information, I think. And I was more or less surprised to see it. So for me, it was a no-brainer. This would improve, but it didn't. So very interesting, I think.
Wonderful. Well, I think this was a great recap of 2025. Maybe before we finish, looking forward into 2026, what do you think we will see in the coming year?
We talking about intensification. We might see the presentation of Proteus using apalutamide around surgery. That would be something very interesting to see. Now that we have ENSERAT being negative, it is really like interesting to see what the results of this study is. I think that is probably one of the most important studies to be presented very likely in next year. And maybe other studies where intensification is done, we'll see if they get enough events to be able to report in one of the major meetings we have scheduled.
Perfect. Thank you so much for being here and giving this interview.
Pleasure. Thank you for the invitation, for the possibility.
Thank you for listening to this episode of EAU Podcast. To keep up to date with prostate cancer developments, visit our educational platform, UROONCO Prostate Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.